All right. So for NSAIDs, our goal was to find the perfect drug for pain. And we want one for pain, we want one for inflammation, we don't want them to do anything else, right? But we will never have that. So the pain drugs that we have are like new opioids, and they are addictive. They have a lot of tolerance and physical dependence, and they are not anti-inflammatory. We have standard NSAIDs. You have the coxibs, which are a subtype of NSAID, and aspirin, which is a subtype of NSAID. And they are anti-inflammatory and they have mild analgesia, but they also have a lot of GI and cardiovascular side effects. So also not super great. Acetaminophen, liver toxicity, isn't anti-inflammatory, also just mild analgesia. So not perfect drug. Cannabinoids, definitely analgesic, lots of other properties and psychoactive properties and sedation, not great. Steroids, even more problems, right? So we want a drug that's going to just be able to do pain, and we want one that'll do pain and inflammation, but be perfect. And that just does not happen. So we're going to look at the kind of the pros and cons of these different NSAIDs and acetaminophen. I know it was a long time. I know we talked about COX enzymes in foundations last year, but I barely remembered we did it. So I don't expect you to. So the COX enzymes are cyclooxygenase, and we have two subtypes. We have COX-1 and COX-2. COX-1 is constitutive, and that meant it's around all the time. And COX-2 is constitutive in some tissues, but we mostly think of it as inducible. So in most cases, COX-2 is not being expressed unless there's damage and you want to have inflammation. They both turn arachidonic acid into some signaling molecules. In terms of COX-1, our constitutive, kind of healthy one, these signaling molecules are just keeping everything running. I would think of them as housekeeping. They're just keeping all the things going right. We have our GI function and mucus, and we have kidney blood flow, and we have enough clotting in our system, all because these COX-1 enzymes are working. So the COX-1 outcomes are pro-clotting, and that's a good thing to remember. COX-2 is available in some tissues and does the same thing in terms of the GI and the kidney, right? But it is also inducible in that it comes up and is expressed usually in terms of an injury. It is anti-clotting. The products that COX-2 make are anti-clotting. So that's important to distinguish from the COX-1. And because it is this inducible problem solving, it has the inflammatory signaling molecules are really doing all of those inflammation that we were talking about in the inflammatory pain section. So they're inflammatory on the other side of the coin. They're kind of immune. They have a lot of CNS effects. They have effects in the uterine muscle, and they have effects in inflammation in the joints. And so there's inflammation everywhere, but in the joints is really a big thing because people with arthritis have particular inflammation in the joints. And so we really want something that is going to target and decrease inflammation in the joints. You think about the uterine muscle, these signaling molecules that COX-2 is producing cause uterine muscle contraction. When do women take Advil? During their period, when they're having cramps. And so all the time if you're in pharmacy school. But one of the reasons that NSAIDs work well for menstrual cramps is because NSAIDs are going to reduce uterine cramping. So we've got inflammatory molecules from COX-2, help GI mucus, help kidney blood flow, are anti-clotting. Those molecules are going to be pro-inflammatory. They're going to cause pain in the CNS and PNS. They can cause uterine muscle contraction, and they can cause inflammation in the joints. This is horrible, I know, but I made like 7 different diagrams, and this was the best one. We've got arachidonic acid, and we've got our COX-1, which is our constitutive, and our COX-2, which was our inducible. All of the things that we're releasing, these inflammatory mediators, are in this big drug class called prostanoids. Most of them are in this drug class. You don't need to know that term prostanoids. I'm really going to just be referring to them as inflammatory mediators. Sometimes when they're released, they're protective. Sometimes they're inflammatory. Sometimes they cause apoptosis. So it's so dependent on the different tissue types that really the only thing that you can really just generalize and say they cause inflammation. So our COX-1 releases a certain set of prostanoids that then cause increase in mucus production in the GI, increase in renal blood flow, and are pro-clotting. COX-2 produces prostaglandins that increase GI mucus, increase renal blood flow, are anti-clotting, increase fever and pain, increase uterine muscle contraction, and increase inflammation, particularly in the joints. The way we get this induction of COX-2 is other inflammatory mediators or tissue damage. So if you cut yourself, if you sprain your ankle, or if you have inflammatory mediators coming in from a prior injury, that can all hit off this COX-2 inducible. I want you to see that these are the same for both COX-1 and COX-2. And I want you to see that these are opposite, the clotting issues. If I were to only have COX-1 going, I would be pro-clotting. If I was only having COX-2 going, it would be anti-clotting. So when we talk about having inhibitors of the COX enzymes, we could inhibit COX-1, we could inhibit COX-2, or we could inhibit both. And when you look at this, this is going to tell you what's going to happen if you inhibit one, two, or both. Let's take something we consider fairly COX-1 specific. And if we block COX-1 and we block all of that, then we're left only with COX-2, right? We'll still have some of these left. We're gonna still have fever, contraction, inflammation. So that's not good. And anti-clotting, but we're no longer gonna have pro-clotting to balance it out. On the other hand, if we block COX-2, but leave COX-1, then you've gotten rid of your fever and your pain and your inflammation. But now you've gotten rid of your anti-clotting and all that's left is your pro-clotting. So that's a problem. If you have a non-selective, which is really what most of them are, then a non-selective NSAID is going to have some amount of inhibition of both of them. So you're going to decrease GI mucus production in both sides. You're going to decrease renal blood flow from both sides. You're either going to be pro or anti-clotting depending on the ratio of COX-1 to COX-2 block. So if you block more COX-2 than COX-1, then you're left pro-clotting. And we'll see that NSAIDs that are preferential to COX-2 have pro-clotting issues. So the inhibitor classes, like I said, we could preferentially block one or another. So if we wanted to block COX-1, or COX-2, we're just going to create drugs that are going to have more preferential binding to one or the other. Here is a diagram that is the ratio of COX-2 to COX-1 block. So if we're up here, we're doing here with the COX-1 preferential block and the COX-2 preferential block. So when we look at the different NSAIDs that are going to block COX-1 and COX-2, you can kind of look at them along this spectrum. You've got the ones that are way up here with a lot more block of COX-1 and the ones down here with a lot more block of COX-2. And your side effects are going to kind of slide down that scale as you go from COX-1 to COX-2 inhibition. So when we talk about kind of the highest COX-1 selectivity, or I don't even want to say selectivity, I'm not going to say specific, where I'm going to say preferential. Because if you look at these actual numbers, the most preferential COX-2 inhibitor that we have is only 10 times preferential. That is not particularly selective to be just 10 times more preferential to block COX-2. So We have our own drug class for these, which is COX-SIBs, which really specifies the COX-2 preferential blockers. And the only one that we have right now still on the market is celecoxib or Celebrex. The one that we have that's the most COX-1 selective is going to be ketorolac or Toradol. And then the ones in the middle that are fairly non-selective are going to be, we're going to have aspirin, naproxen, ibuprofen. Ibuprofen is here probably the closest to completely non-selective as you could get. That's in the middle. We have nabunetone, meloxicam, and diclofenac. And so we talked when we were saying that COX-2 was in charge of anti-clotting and COX-1 was in charge of pro-clotting. COX-1 was in charge of pro-clotting and COX-2 was in charge of anti-clotting. So if you take ketorolac and you are blocking COX-1, but not blocking COX-2 as much, what's going to happen to clotting? Increase or decrease? It's going to decrease. You're going to have more bleeding. Because with ketorolac, you're inhibiting COX-1 the most. COX-1 was in charge of pro-clotting. So now that inhibition leads to more bleeding. If you took celecoxib, which is a stronger COX-2 block, then you are blocking this one. So you're blocking the anti-clotting. And now you're left with pro-clotting. And so the COX-SIBs here have pro-clotting or clot risk. So when you think about, you guys have, I'm sure, covered NSAIDs in terms of top 200 and all of that stuff. And what was the issue with aspirin and those NSAIDs in terms of surgeries? Bleed risks, because those guys are anti-clotting. Celecoxib and the other COX-SIBs that have been on the market all ended up having an issue with increased clot events or thrombotic events. So looking at these as they're on the varying ends of the spectrum is great, but the fact it is a spectrum. So if someone is choosing an NSAID based on what the clot risk is or what the bleed risk is, knowing those, how that goes down the sliding scale of COX-1 to COX-2 is what's going to tell you that. I'm not going to have you memorize for me which of these drugs are where on that scale or what order. But if I gave you this diagram and asked you which one of these is going to be most likely to have clotting or which one is going to be most likely to have bleeding, or asked you something about the properties of them based upon where they are on this, I would want you to be able to interpret that and tell me that. I'm not going to go, oh, is meloxicam more COX-1 than naproxen or less COX-1? The only difference is the COX-SIBs. Celecoxib, you do have to know that that's COX-2 inhibition, because that is technically its own little drug class because of that. Okay. So we've got all those NSAIDs, and you have like probably 13 NSAIDs or something. So what are we going to do to distinguish them from each other? They're all going to have some amount of inhibition at COX-1 and some amount at COX-2 because none of them are selective, but they're preferential. So the first thing that might distinguish them from each other is which block they're more preferential for. You might want one that has more COX-2 block or more COX-1 block. What's another one that distinguishes drugs in the same class? If you had a bunch of drugs that were all completely the same otherwise, but you wanted to decide which one to use, What kinds of things do you think about? I might be being too vague with this. Duration of action?
Yep.
Yeah. Adverse effects? Yeah. Those are kind of the main ones that we're talking about with these NSAIDs. Otherwise, it's just like a batch of 13 different NSAIDs, right? So determining based on their preferential block and duration of action in ADEs usually. So if we had a COX-1 preferential, what was our drug that was most preferential to COX-1? Ketorolac. Is that going to be most pro-clotting or most anti-clotting? Anti, right? So it's going to have the highest bleed risk. It's also going to be really strong at blocking the GI mucus production and really strong at blocking the kidney blood flow. So our ADEs for those are going to be much more GI effects, like ulcers and stuff, and kidney issues. What was our COX-2 preferential drug? Celecoxib. And what are our effects at that? Are we pro-bleeding or anti-bleeding? Pro-clot. Remember, bleed and clot are the opposite, right? So I will try to say pro-clotting or pro-bleeding instead of anti one of them, hoping that you, like, in 2 seconds are going to flip that around in your head. COX-2 preferential are going to be more likely to be pro-clotting. They're also going to now go over and have effects at that whole set of inflammatory and pain pathways that we were interested in. So if you have sprained your ankle and you have inflammation and pain because of it, do you want something that's strictly a COX-1 inhibitor that's preferentially COX-1 or preferentially COX-2? So this is the effect of COX-1 enzyme. This is the effect of COX-2 enzyme. So if you block COX-2, you block these. What's getting is the flipping between what's the physiological effect of the enzyme versus what's the effect of blocking it, right? Just visually. Not like you can't figure it out, but just visually looking at it when you've only heard it like 30 seconds ago. So when you come back to this, if you're not sure about what one of the drugs is doing, come back and say, okay, this is what COX-1 is doing. This is what COX-2 is doing. Cross one of them out and see what's left. Okay, so it's pro-clotting, but a COX-2 preferential would be pro-clotting, but it also have those good anti-inflammatory effects. So it would do all of those things that we wanted it to do. Anti-pain, anti-inflammation, stop uterine muscle cramps, all of that stuff. And then the COX-1/2 non-preferential, which they just call non-selective. That's all those other drugs in the middle. And basically, they all go on a spectrum in terms of bleeding and clotting. But for the most part, you hear NSAIDs, and what do you think of? Do they say, I mean, when you've had it in top 200, do they say NSAIDs you should be concerned about bleeding? In general, that's what is said. When you talk with Dr. Merlot, she's going to point out if there's ones along that sliding scale that you use differently because of different bleed risks. So the traditional NSAIDs, we're going to start with aspirin. That was our first one. And it is prefers COX-1 over COX-2, but not by a ton. Like if you take aspirin, you are still significantly blocking COX-2. But you want to remember that it is preferential to COX-1. It inhibits both at normal dosing. So at a low dose, it's preferential to COX-1. When you get to a normal dose, you're hitting both COX-1 and COX-2. Does that make sense? So a low dose of aspirin is going to actually do something different than a moderate dose. So at a low dose, if all you're blocking is COX-1, then that gives you that anti-clotting effect very strongly. At a normal dose, now you bring in the effects, the pro-clotting effects from COX-2, the anti-clotting effects from COX-1, and you've got all the different sets of effects that can come in from the non-selective agent. But the reason this matters is that you guys have heard of people who are like, oh, you had a heart attack, you're at risk of a heart attack, take 1 baby aspirin a day. That's the low dose. So basically what they're doing is saying you're taking a dose, we're going to give you a dose that's so low that it's not going to even hit COX-2. All it's going to do is hit COX-1 and give you a mild anti-clotting effect. We're even going to keep the dose low enough that we shouldn't get any ulcers either. If you're in pain and you hurt yourself, that low dose is not going to do you any good. That's when you use the intermediate normal pain dose that's going to give you analgesia, anti-inflammatory, and reduce pain. So you have 2 different reasons and 2 different effects depending on low dose versus moderate dose. The good thing about these, about aspirin and the other NSAIDs, is there is no tolerance or dependence, there's no liver damage, and there's no risk of addiction. So that means you can drink Diet Coke and pop aspirin every day all the way through pharmacy school and then chase it with an espresso. And nothing bad will happen, except what will happen? Ulcers. Because these guys decrease GI mucus release. And they increase bleeding. So if you have an ulcer, it can become a bleeding ulcer because it's not clotting up. And when you have a bleeding ulcer, that means you have an open wound gushing blood inside your body, which is not better than an open wound gushing blood outside your body. In fact, one could argue it's worse because you can't see it. So, I mean, aspirin was actually the cause of a lot of deaths because of bleeding to death, back when it was the most commonly used analgesic, because you didn't know. So we want to remember no tolerance or dependence, no liver damage, no addiction, but we also want to remember does cause GI ulcers, does cause bleeding, increases bleeding, renal dysfunction, and it can affect cardiovascular function. And all this, you don't need to memorize anything about this. I was just trying to kind of give you an example of when we talk about using low dose for thrombosis versus intermediate dose for analgesia, like what that difference actually is. The only thing that makes aspirin different from these guys is that aspirin is an irreversible inhibitor. It binds to the COX enzyme and it stays. And the only way that's going to go away is when the COX enzyme is degraded and taken away. So you can have the effect of the COX inhibition longer than you have the drug in your system. The other non-selective NSAIDs, the other ones are reversible. And so they're only having an effect while they're in your system. So if the half-life of the drug in your system is 6 hours, then the half-life of your analgesia and your clotting and all of that, 6 hours. This will be your drug list for these, but you don't need to memorize the order of COX-1, COX-2 preferential. But so you can tell me for these, they reversibly inhibit COX-1 and COX-2. They reduce inflammatory mediator production, And because of that, they're analgesic, anti-inflammatory, and antipyretic. No tolerance or dependence, no liver damage, no addiction. But depending on where it lies in that COX-1 to COX-2 continuum, you could have more or less bleeding, more or less clotting. As if it's more toward the COX-1 inhibition, more bleeding, more toward the COX-2 inhibition, more clotting. And then the adverse effects, really very similar to the aspirin, but just not quite as bad because aspirin was irreversible. At least with these other ones, you get a little, it wears off and you get a little break. So they're not inhibiting the COX enzyme constantly through the day. Unless you took them constantly through the day with your Diet Coke and your espresso. Okay, so the reason I say that is because there was a certain point where I was like standing in the break room and I was like holding my stomach and I'm like, oh man, I think I have an ulcer. And Dr. Albarbri's like, why do you think you have an ulcer? I'm like, well, because I take like 4 doses of naproxen every day and like I drink 5 Diet Cokes. Dr. Albarbri laughed at me, which I deserved, and proceeded to inform me that naproxen is not the best one to take if I was having ulcers. Which would be better to take? Maybe one of those. Okay, so we've got those ADEs are similar to aspirins, but not quite as bad. Again, no tolerance, dependence, liver damage, or addiction. I am not going to have you guys do this. I'm just going to walk through it because we're a little late in the day. So if we want to use the IC50s to compare these drugs, and remind you guys, go back to dose response curves. So the IC50, a high IC50 meant it took a lot of drug to inhibit half the enzyme. So that was the lowest potency. So a drug with a high IC50 had the lowest inhibition of these drugs. I mean, of these enzymes. You guys agree?
Yep.
Okay, so aspirin at COX-2, IC50 was 50. Diclofenac at COX-2, its IC50 was 0.35. And naproxen at COX-2, its IC50 was 1.3. So the highest IC50 was the lowest inhibition. So aspirin had the lowest inhibition of COX-2 of these. Naproxen had a moderate inhibition, and diclofenac had the least inhibition of COX-2. So we'd say diclofenac, inhibition of COX-2. Naproxen and aspirin. So your preceptor tells you that people who've had a previous MI may take low-dose aspirin. Why would this potentially prevent another MI? Anti-clotting. Why would you use aspirin and not celecoxib? Aspirin was anti-clotting. That's why you used it. What would happen if you did that instead with celecoxib? Pro-clotting. And why would dosing only once per day be effective? This baby aspirin, they're not saying dose it 4 to 6 times a day. They're like, oh, 1 per day. Thank you. Irreversible. The binding inhibition is irreversible, and therefore you taking it once a day is enough. And then if I asked you to determine which has more GI bleeding, diclofenac or ketorolac, and I gave you this slide, that's an easy one. That was an easy question. Which had more bleeding, diclofenac or ketorolac? Which one do you think? What caused bleeding? COX-1 inhibition or COX-2 inhibition? COX-1 inhibition caused the most bleeding. So which one is more COX-1? Ketorolac or diclofenac? Ketorolac. So if I showed you this and I said, oh, which one's going to be more pro-bleeding? Which one's going to be anti-bleeding? Which one's going to have more analgesic effect? Knowing what COX-1 and COX-2 do, you'd be able to tell me from a graph like that. Okay, breathe. Got this? It's like what? 2. Yes, nice. Okay, COXIBs. Same thing, except for they are COX-2 preferential. They're also irreversible. So irreversible, don't need to take very often, right? Less frequent dosing. But COX-2 means that it is very good at reducing the inflammatory and pain aspects. Because the inflammation, analgesia, and anti-fever were way more toward COX-2 action. So these guys are going to be much better at these, stronger at those, but they're also going to increase your clot risk. So again, no tolerance dependence, addiction or liver damage, awesome, but they do increase clot risk. And because they're irreversible, what does this mean? DOA over T1/2. So the duration of action lasts longer than the drug is in your system because they're irreversible. We've got aspirin, irreversible, preferential COX-1, other NSAIDs, reversible on a spectrum of COX-1 to COX-2 inhibition. COXIBs, preferential COX-2, irreversible. You can make a song about that, I'm sure. And then APAP,